name is Omar Lateef. I'm the president and CEO of Rush University Medical Center here in Chicago, Illinois. It really is an honor and an opportunity to come speak to you about value-based care. I've been looking forward to trying to come in person to the conference, but the logistics and the period of COVID that we're in right now made that difficult. I hope to present a little bit about Rush and a little bit about our background around value-based care and where the future of value-based care is really going in not only Chicago, in the United States of America, and hopefully for the world. I think we all deserve a better healthcare system and an opportunity to get the right care to the right people when they need it. Again, it's an honor to talk to you, and I hope you enjoy these slides as we move forward. First, a little bit about Rush University Medical Center. Rush is an academic healthcare system in Chicago. Our mission really is to improve the health of our community, and we serve a very diverse community with a lot of extreme illness through integrating outstanding patient care, education, research, and community partnerships. Our hospital system includes multiple hospitals and not just one, which is really important as you talk about value-based care. The larger your network is, the more lives you have the ability to access, help, and shape. Rush includes Rush University Medical Center, Rush University, Rush Copley Medical Center, Rush Oak Park Hospital, and numerous outpatient facilities at Rush that are integrated throughout Chicagoland. It's important not just to share to get some background, but many of the same tools that a healthcare system uses to win many of these awards that you're seeing right now are the same tools that you use to measure the quality of care you're delivering in a value-based care program. Rush was #2 in the country when compared to all academic medical centers in America in the Vizient database. We're continuously in the U.S. News and World Report honor roll, and currently one of the top hospitals in America. And we're also recognized in the world's best hospitals issue this year of Newsweek magazine. We've won nursing awards, technology awards, equity awards, and really awards that embody the type of care that we try to provide at Rush. Rush is focused around high volume, great outcomes for everybody in our community. So let's take a step backwards and talk a little bit about a U.S. perspective in value-based care at large and why that's so important. Financially strong organizations historically in this country, in the United States, were strong because they had a good number of inpatient hospital beds. The procedures that are done in inpatient hospitals reimburse the highest amount of money. Historically, a health system's inpatient market share and bed occupancy rate served as the primary measures for market strength and financial viability. So the more beds you had that were full with patients that could pay their bills, the more revenue a healthcare system would make. Systems that had more beds and kept the beds full were better positioned for long-term success. Inpatient services, things like heart surgery, liver transplants, offered the greatest margin opportunity under healthcare's fee-for-service or volume-based economic structure. And what that means is the more patients you had that paid the bills for the services that they got, or their insurance paid the individual bills, the higher revenue a healthcare system made. So the systems became designed to capture complex illness at the end stage so that you could do those procedures that generated the largest amount of money. If that makes sense, it would have effectively disincentivized without intention, but made a healthcare system not want to get out in the community and decrease long-term factors in care, like obesity, as an example, because it didn't reimburse as much as obesity surgery. So that's an important nugget that we'll refer to as we go on in this presentation. Many U.S. health system strategies are focused on growth through mergers and acquisitions. If you accept historically that the higher the number of beds that you have that are full for fee-for-service patients getting high-margin care, you're thus motivated to get more beds as fast as you can. Well, if you try to go up, at least in the United States, and build a hospital over here, or build a hospital over here, it takes money and it takes time, and there's a large bureaucracy. There's government approvals and all of that. But if you acquire a healthcare system, then you net grow your assets. That would be beneficial to both parties, or there would be synergy. The whole would be greater than the sum of the parts. And why? because healthcare systems that are dialed in and have the services don't have to reinvest in creating those services in another area. They could simply get more beds, and the people they have just work more and are a little busier. This old model requires a substantial amount of capital spend for facility expansion and maintenance, creating heavy fixed costs regardless of how much are utilized. So in other words, the more that you're trying to acquire physical spaces, the more upfront hardcore capital cash that you have to put into this. And you get a relative minimal improvement in improving health of your community. If you make a lot more beds for heart surgery, you're not really improving hypertension in the community. You're just waiting and improving the end stage hypertension patients. So that sets the stage for a future broader conversation, the conversation that I think we should have not only now here internally, but across this country and across the world. And that is, instead of pay for performance like you see here in this graph, moving up, you can get into shared savings, you can get into upside, downside risk, and capitation. Many of these phrases have complicated definitions, but there's a simple way to look at this from a broad perspective. Many organizations are only in the pay for performance area because they're in a neighborhood where patients are paying for performance and they have plenty of those patients. There's no motivation to what we call enter into a shared savings or a risk-based program. It's our belief that within the next 3 to 5 years, more organizations will move to full value-based care, taking on risk. So what does that really mean? What does it mean when you say we're going to take on risk? Well, organizations need to transition the way we think to be patient-centered, but offer incentives for larger numbers of patients, value over care compared to volume. Operational efficiencies to deliver the highest quality care at the best cost. Healthcare, consumer, and patient is at the center of care and delivery, and focus on population-based health care approaches. Healthcare systems that are best positioned for long-term success are those with networks that are high-performing, clinically integrated, capable of generating top-tier clinical financial outcomes, and optimize appropriate inpatient volumes through quality performance and care retention programs. So what does that mean? I'm going to take you back to the slide for a second because I wanted to put that sort of background into the space, into the ecosystem. If I pay for performance, I get a sick patient, I take care of them, I submit a bill, and I get paid. If I do a shared savings program, I get paid before I have to take care of them. So let's say there's 10 patients in a neighborhood, and I take care of all 10. The government, a payer, somebody says, I'm going to give you $10,000 per patient per year to take care of that patient. If I do a good job on 10 patients, that gives me $100,000 at the beginning. 10 patients times $10,000 puts $100,000 in a bucket. If I spend $85,000 taking care of those patients over the course of a year, the institution gets $15,000 they get to keep. That's their profit. That's their revenue, and that's a win. A shared savings program means I'm not sure I'm going to be able to do it this year. So the government says in the United States, okay, here, take your 10 patients. If you save 15,000, we'll take 7,500 and you keep 7,500. You get to share in the savings and we get to share in the savings. So why would you do that? You would do that because what if it took you $115,000 to take care of those patients? That extra 15,000, somebody has to write a check at the end of the year. If you share the savings, you also share the risk. So on 10 patients for $10,000 per patient per year, we'd get $100,000 net. And if I spend $115,000 to take care of those patients in my healthcare system, I'm only splitting that and paying the government 7.5. That's important because it decreases the risk and allows the hospital an opportunity to do everything that I just showed you. Clinically integrate care, get everybody working together, get the right patient in the right place, not overdoing it, not underdoing it, with the right patient for the right care. There's an upside and a downside risk, which you're seeing on this slide. The upside risk is if I do a good job, and the better job I do, the more money I get to keep. If I do a poor job, The worse job I do, the less money I get to keep, and the more likely I'll actually pay a fine at the end. Now you're motivating healthcare institutions to offer a higher quality of care to a larger number of people. And you're also, what you see this word capitation doing, is stopping the highest amount of money that they can give. You just set an amount. All the care in this country is going to be under that amount. So as we shift in this continuum, the hospitals or the health care systems that are best positioned to succeed are the ones that communicate well, are efficient, put the right patient in the right place, and get great outcomes. They'll save more money at the end of the year than the ones that just do a high level of care in an inefficient way. So who does this benefit? Well, this benefits patients. Why does it benefit patients? Wouldn't you rather fix your obesity before you get heart failure? Wouldn't you rather fix your diabetes before a leg needs to be amputated? Obviously, lower costs, better outcomes happen when you hit a patient up sooner, the beginning of the course of their disease, and not when it's very complicated. Providers have higher patient satisfaction rates and better care efficiencies. So as a doctor myself, knowing that you're going to reach out and affect a community in a more positive way at a higher level, patients love that. They feel better and the health of the community gets better. And that has historically made providers feel better. Payers are the easiest, this third bucket. They're stronger cost controls and reduce risk. Payers save money. Like if they don't have to pay for liver transplants by preventing liver failure, it's cheaper to prevent liver failure than have to transplant. That doesn't mean you don't offer transplants. You offer the right patient, the right care at the right time. Suppliers can align with prices and patient outcomes, and society at large benefits the most with an integrated healthcare system focused on preventing severe disease so that you get a healthier, livelier population. So value-based care works, and it works, but you have to get the incentives aligned and you have to get it set up. So we're an academic hospital in downtown Chicago. We have a very large medical school, and we have a very, very ill population. Even within that population, we took not 100 lives, but 30,000 lives. And we got our money sort of up front, just like in that model, and we got to keep what we didn't end up spending. And it ended up that we saved close to $20 million, and we shared with the government 10. They took 10, we took 10. So in the end, it shows you that the model works. The question is how scalable the model is. The question in Thailand is how scalable the model is. The question in Singapore is how scalable the model is. In Europe, how scalable is it? And what I mean to say is doing it for 10 people is different from doing it for 100 people. Doing it for 100 is different for 30,000. So can I say with certainty that if this worked at Rush last year, why don't I sign up 90,000 lives instead of 30,000 lives? And if I do that, do I make 3 times as much money? Will I make 30 million instead of 10? Well, it doesn't work like that because you have to build the resources at the same time you build the scale. So as a nation and as a world, we have to solve the scalability problem now. That's the next level or the next step of conversations. I mentioned a little bit what are the drivers of success, but these drivers become more and more important with time. As you increase the drivers here, if you increase the net number of patients that are in a program, you're increasing your risk. You have signed up to manage a high level of population with a lot of illness for a set amount of money. So look at this bucket right here on the top right, data integration at the point of care. I think all over the world, we can do a better job of integrating healthcare data. Why does one doctor have to work hard to access the information from another doctor? The more we can integrate data, the more time we save and the more efficiency we save. And in this country, the more money we will save. So here's an example of data integration saving you money. You have shortness of breath after getting off a plane from the conference you're at now. You go from Thailand to New York. You get up in New York and you have a little bit of shortness of breath. You're worried, so you go to the local emergency room and get a PE protocol CT scan. That's done after you land at 9 p.m. at night. It turns out it's negative. 2 days later, you have chest pain, shortness of breath. You go to an emergency room and you say, well, I already had the test, but what if you don't remember the test you had? The doctor can't just link to your spiral CT and doesn't know that you had one when you had the same symptoms. and then shift his thinking to look for something else. It may be that you actually have appendicitis presenting differently. They repeat the CT scan because they don't know that you had one before. If the patient doesn't know, or if the doctor's not convinced the patient's accurate, they'll repeat the test. If we integrate data across a city, the state, a country, and the world, we'll do a lot less testing, a lot less rebuilding, reinventing the wheel, and a lot more treatment. We have to reduce barriers to care. So what happens in the United States? Patients that need care at an early time literally cannot get a ride. If you could get a ride or figure out how to work on some of the logistics, perhaps you can get better outcomes. We have to do a better job of managing what goes to an emergency room and what goes to post-acute care. So let's say, what does that mean? That means you had a stroke and you're recovering. You go home. You're going to be weak and dizzy. If you know that and you can't get a hold of your physician, you end up going to an emergency room, which costs a huge amount of care in the system. But what if we had a whole system or program built around you for when you're at home? What if we had a team that can go to your home and figure out how to take care of you? That would be a win. We have to increase annual visits, just regular well checks. Why wait till someone's sick? We have to maximize our network utilization. What does that mean? We have to maximize making sure you get the right care and the people that send you there know what care you had, that the labs that were drawn are in the same computer system for the doctor that's going to look at them. If we don't do that, we're going to, again, redo the same procedures. We have to actually measure for outcomes. Are there some providers that get better outcomes than others? Let's work in a transformative way together to figure out if we can get better outcomes and then favor those techniques. If we don't risk adjust, the whole system falls down. I left it to last. I left risk adjustment and improved quality metric performance, the top two lines on the left. Why is risk adjustment so important? You cannot give the same amount of money for a 65-year-old who runs 5 miles a day compared to a 65-year-old with uncontrolled diabetes and hypertension. The cost of care for both are very different. The cost of care for dialysis patient is different. So there must be a lot of confidence in the people that are adjusting for risk. You must first accept that there's a kicker, more money that should be paid for sicker patients. But the organization still has to have metrics to judge how well they're doing for those patients. Not everybody's going to look exactly the same. And so the system has to allow for risk adjustment. And that's a challenge as a nation that we have to overcome right now. And improve quality metric performance, and I should say quality metric measurement. So that's why I showed you those awards at the front end of this presentation, is Rush became nationally known as a leader in quality. At the same time, Rush put those same techniques into our outpatient care. If the country pays for quality and you can measure your quality, you'll turn the lights on your opportunities to improve so that you can capture more benefit. Care management becomes a huge part of this broad continuum. If we talk about taking on that risk, what is care management? Care management is understand what is a population, understand how risky it is to take care of them, understand how to get to patients, engage them, get them to buy into their care, understand how to manage it, and understand how to measure outcomes. Traditionally, of the 5 boxes you have on the top of this slide, the fourth one, managed care, is what healthcare in America puts all our resources in. What we are now saying is share the resources across the continuum. Create a program that defines the right care for an entire population. Understand how risky it is to provide that care and bring patients in to participate in improvement of their care and measure their outcomes. Don't just operate on their heart. Prevent their heart from needing surgery by figuring out who's eating poor diets, telling them that if they keep eating a poor diet, they're going to get a heart surgery, and get them to exercise. That's defining your population, stratifying your risk, and engaging them. When we do that over time, we're going to do less complicated procedures at a high dollar value and improve the health of a broader population. Look, I'm going to close with some really simple concepts because I think in general, this is a huge subject and a subject that as a nation and as a world, we just have to take on. People with depression do not get help. They do not actively seek for professional help in this country. And primary care providers fail to recognize depression in about half the patients that they see in some studies. Depression screening and treatment with psychotherapy and medications are extremely effective. So if you could reach out to a broader population, adequately screen for depression, not only can you treat it, studies show that you can have an 80% improvement in a 50% of a population. Every other study shows that if you fix depression, people's overall health improves. During 2019 and 2020, the flu vaccine prevented an estimated 7.5 million influenza illnesses. Yet, we don't reach out to populations to engage populations to get the flu. If only half the people in a community even have a doctor to get a flu shot, you're going to have deaths that you wouldn't have had if you were able to reach those populations. These two examples on depression screening and vaccination screening have a dramatic impact on the overall health of an entire community. Dramatic improvement. As many as 93% of cervical cancers are prevented by properly utilizing cervical cancer screening services. Case-controlled studies have shown this. And so if you get screened, you're not going to get cancer, or if you get cancer, you'll get cured at a much earlier rate. So ask yourself, why do we have a healthcare system that does not incentivize screening for depression as much as it does treating a suicide overdose? Why do we have a healthcare system that that reimburses more for treating ARDS from the flu than from preventing the flu? And why do we have a healthcare system that doesn't capture people early on in cancer? Preventive screenings needs no argument. It needs alignment of our incentive structure. As a nation and a world, we have to do better to bring the appropriate care to people when they need it in advance of the last 10 days of life, the last 3 months of life, the last 1 year of life. Let's take our resources and share them in a broader way to the people that need them before they need the highest level, highest cost acute care. If we build systems that do this and we support value over volume and align incentives appropriately, we can really make a dent in healthcare. I'd like to thank you for the opportunity of speaking today, and I hope in years in the future to be there in person. Thank you.